Error. Electricity in line. Override accepted. Infusion initiated.
Welcome to the INS Infusion Room, the official podcast of the Infusion Nurses Society. In this podcast, we explore all things infusion therapy through a real-life conversation, covering the latest trends, new research, evolving standards, and key industry insights. Whether you're an experienced infusion nurse or new to the field, we aim to keep you informed and empowered with the knowledge to stay at the forefront of the profession. My name's Derek, and I'm your host. Let's dive in. Welcome to another episode of the INS Infusion Room. I have expert guests Alicia, Barron, and Kaitey Morgan joining us today, and we have an important topic we want to discuss about patient autonomy versus nursing judgment and being caught in the crossfire as a clinician. What does that mean? Big topic today. I'm really excited, but before we get started, do you both want to introduce yourselves a little bit more, talk about where you're coming from and maybe some of your professional experiences?
Sure. I'll go first. I'm Kaitey Morgan, as you said. I'm the Chief Clinical Officer for the National Infusion Center Association. So we're the trade association that supports infusion centers and the clinicians that work in them. And I'm an infusion nurse by background. I've been an infusion or a nurse, but pretty much always in infusion for, 17 years. So I certainly have plenty of experience with direct patient care and with this topic of getting caught between what the patient wants and what I know is best for them.
And hi, Derek. Thank you for having us on the show. My name is Alicia, and I'm the Executive Director of the Infusion Access Foundation, and I'm a social worker by background and have been working in the chronic disease space for more than 25 years. It just makes me feel really old suddenly. And so working with people with chronic illnesses for a very, very long time. And so definitely have heard from a lot of patients about their experiences with their healthcare professionals. And one of the things that we do at the Infusion Access Foundation is really trying to make sure that we are, working with patients to find out what's best for them, but also the infusion nurses to make sure we're really aligning people in that space, like you said, where sometimes there's not necessarily agreement.
Well, thank you both for being here. So as we jump in, I just want to create a little bit of a background for this. So we talked about what the discussion is, but I want to define a few terms that are really at the root of making these decisions. And the first one is non-maleficence. If you're not familiar with that term, this is a principle in medical ethics that states that a medical practitioner will cause no harm or allow harm to be caused to a patient. Beneficence is the act of making decisions in the patient's best interest. So with that said, what are your reflections on both of those terms? Alicia, we can start with you.
Oh, I was going to call on Kaitey. No, I think, certainly, obviously, non-maleficence, first of all, it makes me think of the evil queen from Snow White, but is definitely one that I think of, the do no harm is typically the oath that all of these healthcare providers take, and certainly something I know that all of the healthcare professionals that I've talked to, they really live by. I think the beneficence one is definitely the stickier part, because I do think sometimes that can turn into more of a sort of feeling like a parental role, like I know better than you, which, listen, you all went to school for a very long time to be infusion nurses, but there is something to be said about the patient's experience and them being the expert in their own disease and the things that have worked for them, and their own autonomy that has to play into this as well. And so I think that's the real point that we're really probably talking about today is where is that overlap between the patient's lived experience and their experience of their own disease, and how that plays into the discussion with the infusion nurse or their healthcare professionals that they work with on what is best for them.
Mm-hmm. Yeah, I think a lot of times, doing what's best for the patient feels like it should mean, and often does, doing what the patient wants, right? But there are times when doing what the patient wants is going to bump up against doing harm to the patient, right? It's a really tricky spot, and I can totally see why you chose to define those terms right out of the gate, because they conflict in a lot of situations.
They 100% do conflict, and it creates that gray boundary, that in between phase, and it puts the clinician at the forefront, on the front stage, to make those decisions within those plans of care. And often that clinician is the nurse. And, there are additional resources like ethic committees and some additional resources that nurses can rely on. But oftentimes, nurses are having to make these decisions pretty quickly, depending on certain scenarios. And within that, I have some scenarios that have emerged within the infusion therapy world, and some case studies that I want to go through and bring some light to some of these scenarios and just have a conversation about what our thoughts are within those. I don't think there's right or wrong when it comes to this, because everything is very much scenario driven, patient driven, plan of care driven. So I just want to preface that. So if we have any listeners out there, just know that can be a little bit of a touchy topic, but just know that I think that the root of all these case examples is that the patient was truly trying to balance what was truly best. So with that said, the first one is around administering IV fluids to a terminally ill patient. So I'm going to go ahead and read this case example. In a palliative care unit, a terminally ill patient with end-stage cancer and a limited prognosis requested IV fluids to alleviate feelings of weakness. The nursing team, guided by the ethical principle of non-maleficence, was concerned that administering fluids might prolong the dying process and cause discomfort. After consulting with the patient and their family, the team decided to administer a small amount of fluids to provide comfort, aligning with the patient's wishes while considering the potential risk. This situation underscores the delicate balance between patient autonomy and nursing judgment in end-of-life care. What are your thoughts?
Well, I don't know if you intentionally did this, Derek, but my first 4 or 5 years of nursing were inpatient oncology, and we did plenty of end-of-life care, and this came up all the time. It's really, really hard for families to feel like by transitioning to comfort measures only or palliative care that they're, quitting or giving up, like they're just taking away anything we were going to do to help their family member. It's really, really hard for families to see, even if, the patient isn't conscious enough to be complaining about being thirsty or hungry. It's one of those like very basic functions that they think, well, dad has to eat and drink, right? At the same time, if you have a patient who's going to be laying in a bed and you're giving IV fluids and now they're getting dependent edema and crackles in their lungs, and it's, it's not necessarily in their best interest. I was really fortunate to work with an amazing palliative care nursing team who could come in and had a way of tactfully having those conversations and would do something similar to this scenario. Maybe start a very low rate of IV fluids and tell the family, here's what we're going to watch for, right? Nursing team's going to assess for swelling or listen for crackles, see if it sounds like maybe this fluid is causing more harm than good to your loved one, and go from there. But it really focuses on education to make that a comfortable decision for the family, to not just feel like we're taking everything away, and giving up.
And I think that's a really important point. When I was looking at this case example, that's what came to me. It was finding what's in the middle. The nurse felt that it was best clinically for them not to have the fluids. Family and patient requested them to have it. So what was in the middle? And what you said is the education piece, advocating and going back into the basis of why this is important and meeting in the middle. And ultimately it had a good outcome because all areas were met in the middle. So Alicia, do you have any other inputs on that case example?
No, I think it really underscores the importance of education. You as medical professionals understand what's happening in this case, the death process. And, there is so much about medical intervention that the layperson does not understand. And so the more information you can provide, the more educated the decision is going to be, even when it's difficult. And I think that is where this is incredibly difficult for the medical professionals, is that you are dealing with people that are in kind of their worst state typically. typically. The family members are under duress, they're under strain, and they may not always be thinking as logically or as critically as they could, but just providing that information and saying, here's the reality. If we do this, then this. And like Kaitey said, exactly, like these are the things we're going to look for, or these are the things that could potentially happen. I think just, making sure that the consumer is as educated as possible, I think is going to be, or in this case, the family also is going to make that decision feel better. I've said this multiple times to lots of people that, there's so much about chronic illness, but just illness in general, where it's things being taken away from you. It's choices being taken away from you. It's powerlessness. And by providing information, you're giving a piece of that power back, and you're letting that person make that decision, which makes them significantly more comfortable with what's going to happen, regardless of the outcome. In this case, obviously, it was going to happen. It was death. But, they're going to be much more comfortable and confident in the decisions that are being made, and usually also more compliant as well.
Yes. Yeah.
Mhm.
So thank you for that for both of you. The next one, let's talk about this one. This goes a little deeper.
Deeper
so-
than death, Derek? Good
I
Lord.
know, really.
Well,
Wow.
hold on.
Okay.
Well, maybe not. Maybe that's the wrong choice of words, but hold on. We're going to
Okay.
go a different direction here. How about that? So
I like it.
refusal of PICC line removal. So this patient had a PICC line. They were planning to leave the hospital against medical advice, and they refused to have the PICC line removed. The nursing staff
Wow.
consulted the ethics committee, which determined that the patient had the capacity to make this decision and upheld his right to refuse the procedure. The hospital informed the patient that leaving with the PICC line would be considered theft, which led to the patient consenting to its removal. This case illustrates the importance of respecting patient autonomy while ensuring safety and compliance with hospital policies. So, lot to unwrap there.
You were reading, so you didn't see Kaitey's and I both react to the theft aspect of that. So I guess
if I were the patient, I think I paid for that catheter and it's mine now. But that is a really hard one. Again, something I've encountered with inpatient care and patients wanting to leave with a line, or with outpatient infusion care and patients with consecutive days of treatment and wanting to have an IV left in, but maybe there are some factors in their behavioral history that make that not a great idea. But they're the patient, and they have rights, and we try really hard to respect their rights all the time. It's really difficult. I would hate to be in that situation.
Yes. And what is the right answer? Can we really say definitely what the right answer is on this? Probably not.
I mean, right? You can't
It's
tackle
very
them.
specific, and there's probably way more details to this that they didn't provide.
I think, this is definitely where I would hope, and I realize this is a luxury in many places, is there a mental health team that could get involved here? Because I am guessing that the reason there's this refusal comes from a place of fear, of like, am I not going to be able to get my treatment? Is there something emotionally attached to that PICC line that is not allowing that person to feel comfortable leaving or safe leaving the hospital without it? And so I would want the mental health team to intervene at this point and say, let's talk a little bit about this. What is it about this PICC line that you are, really relying on? What are you afraid of when you walk out this door? And let's talk about this. And then also let's talk about what's the realities of caring for a PICC line, because certainly there's people that do it, but it's quite involved and you have to be very careful, and there's all these sort of things. And so, again, going back into that educational piece, but really sort of stepping back from this, I think what I also hear in this is there's like panic and overreaction that's happening with, oh my God, we have to convince this person not to do this. And it's like, everybody take a step back and see that this person is hurting in some way and scared in some way. How do we approach that person with that lens and say, how can we help you make the best decision for you? And it might be that, it is against the hospital policy, but that is what the patient needs. And then there's a follow-up that happens maybe, 24 hours later to say, hey, you know what? We just wanted to check on you. We care about you. You left against what we would normally prefer, but we really wanted you to have that opportunity to make this decision. I say, as somebody who's never had a PICC line and is not a healthcare professional, so don't take medical advice from me. But I do think step back and see the emotion behind what's happening there.
Right. Right.
So
And focus on like what is the goal, I think
yeah,
works really well for a lot of these scenarios.
Yeah.
Even with the end of life IV fluid scenario, what is the goal, right? In that
Yep.
scenario, it's aligned. The nursing staff, all the clinicians and the patient and family want a painless, peaceful passing, right? So if that's our goal, we all agree, here's why IV fluids might not help us achieve that goal. If the PICC
Right.
line patient, the goal is to get out of here, and having to wait, half an hour for the nurse to remove the PICC line is the problem, then okay, how can we, address that while still getting the goal? We want you out of here just as much as you want to be out of here. Let's see what we can do to get you there. Aligning on common ground, because otherwise it just feels so antagonistic and confrontational, and it's going to spiral.
Yeah.
So if you found out in the situation, I'm just going to add this in here.
Oh, gosh.
You
Okay.
found out in the situation that the patient had a drug abuse addiction, or potentially had a risk for abusing substances through this particular device upon discharge. That's a tough topic as well.
Mhm.
So in this scenario, maybe that was the reason why, because they had a direct access
Mhm.
without additional injections.
Yeah.
And I've talked to a few clinicians about these type of scenarios. I think that even within this scenario, it goes back to what you both are saying, making sure that we have the appropriate resources, making sure that we have the means to care for the line. Do we have things in places that can prevent tampering of this particular device? I mean, there's options, right? I mean, do you want to add a little bit more into that scenario?
In terms of, yeah. And I
No.
She says, I'm not touching that.
Yeah, no, I think, I'm thinking of those, I think they call them tamper evident devices, because they will say that a
Yes.
determined person is going to tamper with it if they would like to tamper with it, but at least you can know. I think in that situation, I would lean really heavily on education, and, explain to the best of my ability that this PICC line is a straight shot to your heart. So, all the risks that, it's not that, someone with a drug abuse problem doesn't know the risks, it's that they're outweighed by the addiction, right?
Yeah.
But still, you have an obligation, and I think it can be effective to say, injecting through your skin, say your body has a good fighting chance to kill whatever bacteria gets in there before it, starts growing in your heart valves. But this line is a straight shot to your heart, and if you get sick, you'll get really sick really fast. And again, you can't tackle them and pin them down and yank out their PICC line. So the best you can do is say, look for these things, fever, shaking, chills, whatever at the site that happens, go to the ER, because it's not going to have a good outcome.
And if we're basing this clinical decision alone on the patient's risk of illegal substance abuse, we are almost doing them a disservice, because that patient deserves to have quality treatment for their infection, be able to get safe home infusions, or infusion center, whatever their choice is, to get that medication for that duration of treatment. They too deserve that right, regardless of that particular situation. It's finding the healthy medium and finding the solution to that issue, and just making sure that the patient is the safest care is rendered, and that they're working within patient autonomy as well. So again, gray area, depends on the patient, depends on how complex that particular situation is, but if they're meeting the majority of the criteria on that checklist for safety, and we have an issue that's a potential risk, I mean, where do we draw that line, and what outweighs the other, right?
Yeah. I think it's definitely a scenario where you check your biases as well, to say, because I mean, how many times have we heard about people that were denied pain medications in emergency rooms because of a, lack of somebody checking their biases and saying, well, certain people don't respond to pain medications the same way, or this is just drug seeking, and, it's not always easy to do. I know you have to make really fast clinical judgments, but I do think, take the time to step back and say, why am I reacting this way? Where does this come from?
Mm-hmm.
All right, let's move to the next one.
Yikes!
So
I'm a little afraid of the next one.
No, it's okay. It's okay. It's okay. Like, hey, we need to have these conversations within our industry. So thank you both for stepping up to the plate for this.
It does feel a little like my social work licensing exam, though. It does. So I'm getting a little sweaty right
You're
there.
the perfect
No, I'm
person
joking. It's
for
fine.
it, right?
It's fine.
The next one, emergency central line placement against patient wishes. So this happened in an ICU. A patient received Levophed or norepinephrine. It was running at 10 micrograms per minute, had it infiltrated IV line, and it was causing pain. The attending intensivist recommended placing a central line to prevent hypotension and potential cardiac arrest. However, the nursing staff discovered that the patient's chart indicated do not escalate care order, which included avoided invasive procedures like central line placement. After consulting with the ethics committee and confirming the patient wishes, the nurses decided against the procedure, prioritizing the patient's autonomy over the physician's recommendation. This scenario emphasizes the importance of adhering to advanced directives and respecting patient preferences.
Mm-hmm.
What are your thoughts?
Yeah, as hard as that is for the clinicians who know, if we could get you some Levophed, we could help you turn this corner and potentially recover versus no escalation of care. That's really hard to be part of that scenario or witness that scenario, but ultimately patients have that right to make that decision. And it's rare, I think, or not common enough that those wishes are made known when patients are or when people are in a position to make them known, rather than waiting until they're in that situation and the family has to try to guess what they might want. That's always really hard. So, kudos to our imaginary patient for having an advanced directive, and lots of sympathy and empathy for the clinicians and the team who has to be there to help navigate that situation.
Mm-hmm.
Yeah. I mean, I certainly think that it feels like, following the wishes of the patient, especially since it is an advanced directive, is a very important piece of that. I think what I would say is, again, this goes back to my comment about, like, you guys know a lot about medical stuff, but I don't, so everything you just said, I was like, yes, that seems hard. And I don't know what that means, and so as people are, putting together advanced directives, making sure that they're actually understanding, like, what am I agreeing to and what am I saying I don't want. I do think that's an important piece of whoever's sitting down to put these together. I know that it's probably like something, I'm sure there's like a legal Zoom I can do for this, but understanding what am I agreeing to, what am I telling them I don't want, because it could be that if they would have explained this exact scenario to a patient, say, well, this is the thing that could happen and this is what this looks like, they might say, no, actually, I'm cool with that, but I don't want CPR or whatever it is, and I agree with Kaitey, like the fact that this patient has this outlined and that everybody understands it and knows it and looked at it is somewhat remarkable. I've definitely heard of at least probably 3 scenarios where it was an emergency situation and there was intervention that was done. And then after the fact, it was like, oh, this person had a DNR, kind of thing, or this thing was in place. And it went against what they had asked for, and so, yeah, it's this. So this is a really tough one because it just, when it is that emergency, there isn't always the time to reflect on, what's legally available and what were the choices. So
yeah, you really need the time that most clinicians, I think, don't have to have a really in-depth conversation about, okay, you don't want escalation of care. What does that mean, right? That maybe you hear, I don't want to live on a ventilator, right? But don't think of the scenario of, I might just need a central line temporarily. The palliative care team that I referenced earlier that I was really fortunate to work with, they had the time to have a lot of those conversations. And when I would participate in them or, hear them, it was amazing to me. If you just, like, the physician would come in, and this is no knock on physicians, they're doing amazing work as oncologists, I can't imagine, but say, if your heart stopped beating or you stopped breathing, do you want us to do CPR, do everything we can? And they'd say, yeah. And then palliative care would, look at this stage 4 terminal diagnosis and say, okay, let's talk about what that means. CPR means you'd be pressing on your chest through, all going into detail about it, put a breathing tube down your throat, hook you up to a machine. And when people understand it, they go, oh no, I don't want that. okay, well, you
Right.
did just agree to being a full code and, having us do CPR. It's just a huge
Yeah.
education piece that, unfortunately, there's not always enough time for.
Well, I wanted to get Ask IV's weigh in on this.
Yeah, I've never thought to ask Ivy such questions. It's more like a specific
Yes.
standard or something, not ethical
Yeah.
dilemmas.
So for listeners who don't know who Ask IV is, that's our AI chatbot that sources the standards of practice to answer clinical questions. This is free for everyone, up to 10 clinical questions for non-members. And then, of course, INS members get unlimited usage of Ask IV. So I wanted to get her weigh in on this. What did she say? What does the standards have to say about this particular topic? And I wish I could share this and really put it out there for everyone to read, but because we can't, because we have some audience members who are just completely listening in on this, I'm just going to read it. So I asked her the question: a patient autonomy versus nursing judgment. What should be considered from the standards of practice? So, in regards to patient autonomy, the standards state that the ethical principles are foundational for decision making. Clinicians are expected to act as patient advocates, maintain patient confidentiality, safety, and security, and to respect, promote, and preserve human autonomy, dignity, rights, diversity, equity, inclusion, and accessibility. Care is to be individualized, collaborative, and evidence-based, culturally sensitive, and appropriate to the patient's age and cognitive level. Clinician decisions, including device or product selection, should be influenced by the clinical evidence of positive patient outcomes and not by commercial interest or conflicts of interest. So that was her response to patient autonomy. And then she moved into nursing judgment. Registered nurses are expected to perform independent nursing interventions using appropriate clinical reasoning, nursing judgment, and critical decision-making skills. The scope of nursing practice is described as broad and flexible, focusing on the combination of knowledge, judgment, and skills in direct patient care, advocacy, supervision, delegation, leadership, management, research, and policy development. Activities require clinical reasoning, such as nursing judgment and critical decision-making, cannot be delegated to others. So pretty straightforward for both those. Would you agree with both of those definitions?
Mm-hmm.
Or how she defines those?
Yeah, I think so.
All right. And then she goes into balancing autonomy and judgment. So the standards require clinicians to integrate evidence-based knowledge with clinical expertise and patient preferences and values to provide safe, effective, and patient-centered infusion care. Nurses are accountable for their actions and must accept responsibility for their decisions, including those that involve balancing patient wishes with clinical judgment. That's not a tough place to be, right? When concerns arise around the appropriateness of orders or care plans, these should be addressed collaboratively with the healthcare team, always considering the patient's best interests and preferences. And I like that. I like how she ended that, because that's exactly what we found in the case scenarios that we saw today. That was heavily weighted on, and patient preference was at the highmost respect within each one of those case scenarios.
Mm-hmm. Mm-hmm. But at the same time, you can't just say that was, picture, I think the scenario that comes to my mind first, and probably most of, INS's audience and listeners would be, is when the patient says, oh, they always put my IV, right here, right where my thumb meets my wrist. That's where they always get it, because there's a nice juicy vein there. And that that's a terrible idea, and that you should never
Absolutely.
be doing that. But that's what the patient wants. And so, I've certainly heard of the solution to that as being, well, just document that the patient refused for you to put it where you wanted to put it, and you put it there per their, request, per patient request. But, even.
But then what happens whenever we have nerve damage to that area,
Exactly.
or we have
Exactly.
extravasation because of the area flexion?
Exactly.
Or,
And it's
the
not
list
going to
goes
help
on
you
on
the
right?
witness stand. I've been going to INS meetings for like 20 years now. Since before I was even a nurse, I would go with my mom and listen to these legal case studies, right? And so I started my nursing career with that advice of, like, put yourself on the witness stand and defend the decision you're making, right? And so to say, yes, I did this procedure, put an IV in a really bad place because the patient wanted me to, even though I knew it was not meeting my duty to uphold the standard of care, that doesn't get you out of it. That doesn't get you, a free pass for the consequences of that.
So if our advice, and this is what I'm gathering from our conversation today, what we want people to walk away with, is they should consider their scope of practice nursing judgment,
Mm-hmm.
and apply patient autonomy within these scenarios. Which one holds most weight?
I think the thing that you missed is the education piece.
And the
frankly.
education,
Mhm.
yes.
Yeah, I think to me that is the most important piece, because again, the more that you're providing the information that the patient can use to make a better judgment,
Mhm.
the better off you're all going to be, because then you will be in a situation where, if Kaitey said to me and I said, I want it to be right here next to my thumb, whatever. And she said, actually, you're going to have a bunch of nerve damage if we do that, or it has a higher likelihood of extroversion. Like, I would say, oh, okay. Yeah, I didn't know that. Let me, I probably would make a different choice. Or I might just say, you're right. I understand that. And I'm willing to take that risk. That it feels different to everybody involved.
Mhm.
It might still not be able to be defended on the witness stand. Sorry, Kaitey. But I do feel like, it's, I know. But it's now I've come in even more informed. Like, I might have had an opinion, but now I have a slightly more informed opinion as the patient. And so I think that's the piece. It's like, it's balancing the autonomy stuff. Again, going back to the balance part of that.
And
That's
almost,
I'm choosing none, Derek. I'm choosing
Right.
that's okay.
All
And
of
that's
the
what I
above.
thought. That's what I thought you would say, because I feel like this whole conversation went into advocacy, right? How do we
Mhm.
advocate as clinicians, nurses, anyone in the healthcare? How do we advocate for that patient for what is truly
Yep.
best for them based upon holistic needs, their personal
Mhm.
preference? How do we tie it all together? And that's the beautiful thing within healthcare, is that we do that every single day. So what does advocacy mean, and why is it so important?
Yeah, I think that's what came to mind when we're talking about this. Is advocacy is one of the core functions of nursing, right? Is advocating for your patients, helping them, get what it is that they need out of this care interaction. So we are advocates, and sometimes that means saying yes and doing what the patient is asking you to do, and sometimes that means explaining why that's not a great plan, and why you'd like to take a different route. That's all part of advocacy.
100%. Yeah, I think advocacy in this scenario is that you and the patient being aligned as much as possible. And that includes perhaps being the advocate to the healthcare system as well. It might be that the patient isn't getting what they need from the system that you're working within, and you might have to be the conduit for that patient to be able to get what they really need. And so sometimes that's you and them against the world, and sometimes it's you and them having to have a discussion where you're being the educator in that moment, or you're saying, we're going to agree to disagree, but we're going to do it as safely as possible. So I think that's a big piece of it. But yeah, advocacy can be a lot of things, but I think the more that you can help patients understand that you're on the same team and that you are their advocate, I think, again, you're going to have a different experience. You and the patient are going to have a different experience.
Yeah, we always want to listen and educate and explain, and there are just going to be times when we have to say, I hear you, but here's why I'm recommending something different, and then explain the why and redirect them towards safer options, and that's advocacy too.
Yep.
I was having a conversation with a good friend, and an ex-coworker, and she brought some additional insight to this topic just through our conversation. And she made the mention of the current culture within advocacy within nursing, and how she's felt, and from her personal experiences. And again, this could be from her geographical location. There's lots of different things, but from her professional experience recently, she's felt a shift in culture in regards to advocacy, and that many clinicians are shying away from stepping up to the plate, and it's almost a sense of minimalism, and just providing what the patient needs on a minimal level, as opposed to going above and beyond. That was interesting, because from my standpoint, I work with clinicians who are really focused on improvement and quality. So my perspective is not that.
Mhm.
Can either one of you talk on that? Are you seeing that in your areas, or do you have any specific examples that could validate these claims?
I mean, I've been out of direct patient care for 5 years now, but I will say I see or did see a little bit of a shift in clinician advocacy when the focus became more, and not to get too political here, but focus came more on patient satisfaction. If the patient is only going to give you a good Press Ganey score if you put the IV where they want it, and that is going to trickle down to your departmental funding or whatever, your performance evaluation, right? Like all of those, like those metrics are based on the patient getting what they want, and so I think that does cause burnout for clinicians to say, look, it doesn't matter what I know. I think it's really easy to just burn out and say, okay, I'll do what I have to
I'll do
do.
what you ordered.
Mm-hmm.
Yeah.
Exactly. I'll give you an
I won't
antibiotic for your
argue.
virus.
I've given you this standard 700 times and you still are ordering this,
Uh-huh.
and the patient seems to be educated. What do I do? What else do I do? And that's a whole nother topic. We're not even going to go into that because that's open a whole nother can of worms. But
And unfortunately, this is a soapbox I'm on pretty regularly, but I also think this is perpetuated by like the struggle that it has become to get anything covered by insurance. When you know that whatever you order is going to be a fight, at some point you go, okay, I'm going to do the minimum so I can cover my base and say, yeah, I did that. I can check that box so that the next time the patient comes in, they can say, but I did that. I've covered that step. I can now move to another step. I mean, I get migraines, full disclosure. And I went to my doctor and said, my old migraine medicines it isn't working as well anymore. And she said, yeah, it's a much older medication. These are the new ones. This is probably the one I'd recommend, but you're going to have to take this other one first because you're going to have to check the box and say you went through that step. And that step therapy has got to be so incredibly exhausting for you guys as clinicians to know that you're not able to provide the patient with what's going to be best for them, that you have to just check that box. It's so demoralizing, I would imagine, as people who go into a helping profession because you want to be helpers. It's incredibly demoralizing, I think, to have to just constantly jump through the hoops that are being put in place by people who are not educated, that got MBAs, and that are not thinking about this from the patient perspective. They probably never had to use the hospital system. And if they did, they certainly understand why this is crap. And so I think there is just a level of just exhaustion and demoralization, if that's a word, that I think layers on top of all of this to just get people to kind of go, yep, I'm going to do the job. I'm going to do it fine. I'm going to do something that's probably not going to hurt the patient, but maybe it's not the best because I'm not going to get an argument.
Yeah, we're going to keep them alive.
Yeah.
That's really great points, and I could talk about this with you guys forever. You have such wonderful
soapbox
viewpoints. No, you have wonderful viewpoints. I love our discussions. I know we had some good discussions at INS, and I'm looking forward to coming out to NICA in a couple weeks.
I know. I'm so excited.
Yes.
May I ask you guys a question as healthcare professionals? I'm throwing you a curveball, Derek. I'm making your own guest.
I like it. Let's do it.
I'm curious from your professional perspectives, as patients, what can they do to make sure they're expressing their needs and their desires for their healthcare in a way that really kind of gets to the heart of what you guys need to hear as nurses? Because I do think sometimes if you speak the right language, it gets interpreted in a different way. So I'm curious, what's been a way that a patient or patients have come to you and really expressed their needs and their desires in a way that like you were like resonated and you're like, I get it. I got it.
I can start with that, Kaitey. I think for me, within my practice, I feel that it's always a struggle to make sure that your patients are truly grasping what you're giving them, what you're educating. So the repeat back method is so important. So if I know that the validations for which I'm trying to encourage them to do whatever it may be, or procedure, moving forward the procedure, whatever it may be, is always going to be truly teaching them to why this is important. What are those outcomes? What is everything associated clinically within this particular decision? If they're able to repeat that back to me, I know that they truly understand what I'm saying. And then it shows me that even though they know the outcomes, that they can make that decision and that they're truly informed and have informed consent to make that decision. To me, that makes me feel more comfortable as a clinician to know that I did my job to make sure that they truly understood this, and was able to be informed enough to decline or accept or whatever it may be. So I think that's important, just the repeat back and then make sure that they truly understand what I was saying.
Mhm. Yeah, and I think aligning, objectives, goals with the patient, like we talked about earlier, by being curious, instead of just jumping right into arguing your case for why this is, the way it should be done. I think clinicians need to stay curious and try to get to the heart of what it is that's driving this decision for the patient. If it's, I don't know, say they want an infusion medication, they want it administered over an hour instead of 2 hours because they have somewhere to be, right? And if you don't know that, and it just becomes an argument of, no, I'm going to follow the PI and do it over 2 hours, and they say, no, that last nurse did it over one, then you're not going to get anywhere. But if you get down to what is the motivation behind this decision that they're making or not making, then I think that's the only way you're going to get to it's not me versus you, it's us versus the problem, and come up with the best outcome.
Did that answer you?
How'd we do,
It does, yeah. I love that.
Yeah,
No, you guys did great. I love that because I think both of these are super important of like checking where the motivation is coming from, but also making sure that you're recognizing the understanding both ways. I think both of these are really, really important pieces. So thank you.
We have
great advice.
It just made me think we have a session at the conference about de-escalation and having conversations with patients when you're in this sort of heightened state. That I think, if this is resonating with anyone who is coming to the conference, I would say check out that session, or come join us in Miami and check out that session about, how to handle these patient situations, but stand firm in your clinical judgment, and de-escalate that situation.
Yeah. And Derek's sessions too. You got to come see Derek's.
Yes, I will be there. I'll be on stage. Yes, I'm excited. Can't wait.
I know it's going to be a great time.
Unfortunately, this is going to air after.
Oh, shoot.
But it's okay. I know.
That's right. That would be
well, hopefully you've seen Derek's session.
Yeah, absolutely. Hopefully you have good feedback that you can comment on whatever platform you're using to listen to today's episode.
Yes.
We'd love to hear that. We'd love to hear what your experience was at NICA. So that's a good place to end today's conversation. Like I said, we could talk forever. Do you have any final thoughts before we wrap up today?
No, this was really fun, Derek. Thank you for throwing these case scenarios at us, because I think, we can say what we think is best until, till the cows come home, but it's not until you actually have to put your ethics into practice that you really start to say, okay, this is the reality of what it is. And so I think it's important conversations to be having and important practices to do, to make sure you kind of exercise those muscles before you need them, and before you've got a patient lying on the table that needs a central line and you go, what the heck do we do with this? So thank you.
Exactly.
This was fun.
Yeah, I agree. It was fun, and it's a really important conversation. So thank you for having us and talking about this, and thank you to INS for everything you do to support infusion nurses. Between INS and NICA, I think we've got a pretty solid tag team to make sure they're backed up with education and tools and resources to handle whatever walks in the door.
Yep. And to keep patients safe and happy.
That's right. Moving the needle in infusion care.
Oh, I like it. I like it.
Oh.
All right. Well, thank you both for coming today. As always, I'm your host, Derek Fox, and it's been a pleasure sharing this important discussion with you. Remember, knowledge empowers us to make informed decisions. Until next time, stay informed, stay curious, and keep gaining knowledge. Thank you for tuning in.
Infusion complete.